AI to the Sky, the podcast for those who build the future, not those who fear it. AI, automation, disruption, no mercy. Hosted by Joseph Fail.
This episode is powered by Rocket AI.
OMASAN, let's kick things off with a quick icebreaker. What's your show or podcast these days, the one you never miss or skip?
There is one. So it's not a TV show and it's not a podcast per se. It's a show on YouTube, and it's called Pop the Balloon or Find Love.
Oh,
Yeah,
that's really interesting.
it's a particular one. It's done in the US and it comes out every Wednesday evening at about 6 o'clock my time. And for some reason, I have been addicted to it. I look forward to Wednesday after work just so I can watch Pop the Balloon and Find Love. So yeah, that would be one uh probably program or show that I tend to watch.
To know.
Yeah.
Well, at AI to the Sky, we don't talk about hype. We talk about real decisions where making the wrong call doesn't just mean losing money, it means losing lives.
Mhm.
Today, we have with us OMASAN EDUN, an NHS leader in AIEthics, working in one of the most demanding healthcare systems on the planet. His expertise is in the most critical area, where the urgency of saving lives collides with the risk of losing trust in technology. OMASAN, thank you so much for being here.
Thank you. Thank you for having me.
No, of course.
AI is revolutionizing healthcare, but someone has to make sure it doesn't destroy what makes healthcare human. Omasan, you are right at the front line of that fight. How do you get into AI ethics and keeps you in this battle?
Yeah, that's a great question. So for your listeners, just a bit of my background. I trained as a clinician, so I did medicine in university, graduated as a clinician, and practiced medicine for a while. Then moved on to public health, where I've done most of my work. However, recently, obviously, with the whole AI hype and AI boom happening, I started asking myself, how can this impact healthcare? How can this, seeing all of the good things that were happening in other areas and other sectors and industries, I started to think, how can the health sector best leverage that technology to improve the quality of care that we provide for our patients? And I started looking at tools that have been developed, models that have been trained, in areas of predictive medicine, in areas of diagnostics and precision, population health. And it was really fascinating and exciting seeing all of the fantastic things that were happening. But then I quickly realized that, hang on a minute, there are risks to this, and it's not all nice and shiny, like, it's being portrayed and sold to the rest of us. There are actually consequences and risk associated with deploying this. And that came about because I started noticing patterns in, inequitable distribution of how the tools are being applied in such a way that some minority groups were being sort of excluded or misdiagnosed because of, for example, the data it was trained on. So that got me really thinking, and I said, oh, okay, I need to know more, rather than just saying or going beyond how we can impact health in a positive way. I need to also be very conscious of the fact that there are risks associated with this. And I started looking at what are the regulations behind this, what's the legal framework behind implementing tools like this. And that's how I got into AI ethics. I started doing a lot of research around what are the ethical implications of using AI, how can we use AI more responsibly, how can we design AI with a mindset of being ethical and responsible and using it for the right things to target the right population. And so that's how I got into it, did a lot of research, then went on to do a certification in AI governance. So obviously now I'm a governance professional in AI, as it were. So that's how I got into AI. It's just mainly from interest and seeing the risk, and more importantly, realizing and understanding the scale of the impact if you were to go wrong. With other technologies, you would have, if things go wrong, you probably would impact a small number of people. But with AI, you can see large communities being excluded. So that got me really thinking.
Oh yeah, yeah, you're right. And I was seeing that too, because I really like this kind of field, and I saw an example, but I'm sure you did it too. It's about the experiment that did Dr. Winnie too, right? It was
Mm,
about bias, and
yeah.
yes, you are definitely right. So, Omasan, in healthcare projects, urgency saves lives,
Yeah.
but bad AI destroys trust. How
Mhm.
do you personally manage the trade-off when lives are on the line?
When you say that statement, urgency saves lives, it's almost like that's the foundation of medical practice. In short, I'm one of the medical practitioners who believe not just being quick to make decisions or make diagnoses. We need to go a step earlier in the disease pathway in terms of prevention. So how quickly you can prevent something from happening gives you a better chance of either picking it up early or treatment further down the line. Having said that, AI has the opportunity to fast track that process, giving us that, timely intervention of handling medical conditions and being able to spot illnesses early. So there is that incentive for people to accelerate the growth of, AI designing tools to be able to help us in medicine. But just like I mentioned, there is that flip side of, if you move too quickly, you stand the risk of, deploying tools that are not necessarily safe. And there's this whole mantra narrative in the AI space now, where the slogan is move fast and break things, right? Let's get going, let's get cracking, you know, the quicker you fail, the quicker you learn, and then the quicker you can get better. While that is very applicable and useful in a, let's say, the tech space, for example, where the impact of your failure is not the lives of people, you can take that risk. In healthcare, that's not the case, because your failure is directly linked to the life of somebody, and we need to understand that. So my practice and what I preach is we cannot sacrifice safety and transparency for speed. It's it's not one of the trade-offs we should be making. We need to get things right. We need to get the basics right, because we know that the impact is the life of people. Now, the counter argument to that is, well, the health sector will be left behind in this AI race. But I think that's a risk that I'm willing to take. I'd rather we go slow and get it right than rush through the process and then think back in hindsight to say, oh, we could have saved X number of people if we had just taken the time to learn, to regulate, and do things properly.
It's brutal. Yeah,
Yeah.
definitely. Because in business, losing trust means losing customers, but in healthcare, losing trust means sometimes losing people and
Yeah.
lives. So yeah, that's another league entirely.
And
So
in medicine or in healthcare, it's very difficult to gain trust. It's a very slow process to gain people's trust. But then trust can be lost so quickly, and to rebuild that trust takes a lot of effort. And once that happens, you lose not just the patient, you also lose the enthusiasm from clinicians and doctors to even want to adopt AI. So when you rush these things, it further, impacts you in your adoption further down the line.
wow, yeah, you are definitely right. So Omasan, what's one ethical red flag in AI implementation you've seen that maybe others ignore? Why is maybe let's call a silent killer in public AI projects?
Yeah. So, as most people would know, there is no AI without data.
Yeah.
AI is trained on large amounts of data. So the name LLM is, as it says on the tin, large language model. It's been trained on loads and loads of data. But what we tend to see, especially within the health sector, is the data that is being used to train some of these models do not represent the population that this tool or this model or this innovation is meant to serve, because the data isn't just available. So what you tend to see is these models will do very well given the data that they have and they've been trained on. They will do so well in the testing environment, but by the time you deploy those tools in the real environment, because the data in the real environment is quite different from the data it's been trained on, you begin to see a disparity in the outcome. That's where you begin to see misdiagnosis, for example. You begin to see inequity in the distribution of health. And there's a very good example in the US where AI tools were wrongly or inaccurately predicting false or worse health outcomes for Black people. Now, when it was traced back, it was realized that the data that was used to train the model did not really include a lot of data from the Black community. And what that then showed was it was a more wider systemic problem. Now, usually data that you use to train models would have come from electronic patient records, for example. It would have come from studies that were done, scientific researches that were done, right? Now, we know historically, because of access to healthcare, whether it's financial or educational limitations, minorities don't go to the hospitals, so their data is not being collected. Minorities don't necessarily partake in research because, again, there is this fear for research. If you go back history, there's a Tuskegee experiment that was done on Black people. So you have all of these social factors that prevent minorities, Black people from going into healthcare, using healthcare facilities, which then translates into less data about these people. And then you then use that data, that's depleted, to then train an AI model to use on this same population. You begin to see the mismatch. And then by the time minorities end up in the hospital, they are already in very bad conditions. So the data you have about Black people or minorities that have ended up in the hospital are people with worse conditions. So the model automatically would correlate minorities with worse health outcomes. So you begin to see the model predict minorities as having worse outcomes when it's not necessarily the case. And that's a silent killer, because if you don't catch it on time, you might begin to plan someone's healthcare path or process or plan based on a wrong diagnosis or a wrong prediction. That's why usually we tell people, when you design your model, you have to test. You have to do audits to check that the performance and the accuracy is consistent across whether it's age, race, ethnicity, so that when you begin to use these tools in real life, you're getting the accurate picture. And that's the silent killer.
Definitely.
Yeah.
Yeah, imagine many people think ethical issues are just maybe psychological debates, but
No,
here we are talking about biases,
yes,
literally, that could leave entire communities out of, and that's excluding people from the healthcare, right?
absolutely. Yes.
Wow, I love this conversation. Thank you, Omasan.
No problem.
So, Omasan, tell us about a real AI deployment at the NHS where things maybe were unexpectedly right or dangerously wrong. What happened? Maybe what did you learn about this experience?
So I wouldn't necessarily say unexpectedly right or wrong, because a lot of the deployments happening within the NHS now are pretty much in their pilot stage. So you still very much is happening within confined spaces or more like test environments. And there is still that human factor in fact checking or ensuring that the AI is right. There was a pilot that was done, a 2-year pilot that was done in Northern Ireland. It was AI being used in imaging and radiology, and that's imaging and radiology is one of the areas in medicine that has really seen advancement in AI use, especially within the NHS. So this particular AI tool was being used to detect bone fractures. Sometimes you have very thin line fractures that the human eye can miss. So this tool had been trained, on loads and loads of images, X-ray images, and it was put into test, and they compared what, going back 2 years, what the clinicians had picked up as a fracture or have missed out as a fracture, and what the AI has picked up as a fracture and labeled and put a box around and say that's a fracture. Once that was done, and it was done retrospectively, but also prospectively going forward, and it was compared, and they saw that there was an increase in the accuracy of the AI to pick out fractures the human eye did not pick. I think it rose from about 87% to about 95, 98%. And that's very good,
Yeah.
and it was quick. The turnaround time of doing the X-ray, reporting the X-ray was also quick. So the impact of that was they had less people turning up to clinic with wrong diagnosis, because you could have said, oh, there's a fracture, but then there's no fracture. Then they would have wasted their time coming to the hospital. Or there is a fracture, you have missed it, you've sent them home, and then 1 week later they come back with complication. Then that's extra work for you, that's extra cost to the system. So by the time you do all of your analysis and trace all the lines, you can see that if you improve the accuracy of your diagnosis, one, you will improve the experience and the outcome for the patient, but you also reduce the burden of work for the clinician, and you also save the hospital some money because there's no repeat test, there's no repeat hospital visits. So you can see how every stakeholder within that patient pathway can benefit from the AI. But what then happened was that was the first version of the tool. With AI, it's always rapidly evolving. They're always doing new upgrades. Then they designed, or they trained a second version, which was an upgrade from the first one. And now, going beyond just identifying fractures, they had now trained the AI to identify bone lesions. By the time it was put into test, they found that the AI was picking up things that weren't lesions, but the AI has picked up as lesions. So by the time they compared the AI output and the human output, there was a drop in performance, right? So they had to scale back, using the upgrades, and then stuck to the original version that they had. And that's very important, because sometimes, because you think the first one worked, oh, it's called an upgrade, so you would think it will be better than the first one, but no. And that's why we always stress that before you deploy these tools into production or into real life scenarios, you must test it. You can't just assume that because it's a later version or is a newer version, is automatically better than the older version. So they have to scale back on that, go back to the original one, and continue using the original one while they continue to test and train the newer version to be able to identify things, a bit better. So that's a scenario within the NHS or within the UK, that you have seen the same tool, but different versions work very well, but not very well in other cases.
Beautiful example. And yeah, so human supervised control is critical, right?
Very critical. One of the key things that is being pushed now is the concept called human in the loop, where you do not allow the AI make the decision. At the moment, where we are in healthcare, is the AI is a decision support tool. it doesn't make the decision for the clinician. The liability of that patient or the diagnosis or anything you do still lies with the clinician. You can use the AI as a tool to augment and complement your care, but the AI shouldn't take over the care that you provide.
Yeah.
Yeah.
I agree with that.
100%.
So, OMASAN, what practical framework tools or techniques do you use to implement AI, but in this case, ethically in high pressure, highly regulated healthcare?
Yeah, that's a good question. So, first of all, you need to think about, what are the issues that we face on a daily basis, right? One of the things is in healthcare in the hospital, one of the first things we think about is patient safety, right? Second thing we think about is bias and fairness. The other thing we think about is transparency. And I think the fifth thing, amongst many other things, is data protection. So one of the frameworks that I would usually use is you have to think from a patient safety mindset. Your design has to be patient safety driven. You have to have the patient at the center of the product that you're building. And that means you're designing your product that must pass clinical safety evaluations. You cannot deploy a tool into a hospital without having done a clinical safety evaluation to ensure that you are not unduly causing harm to a patient. That's the first one. The second one is you have to test that your tool is not biased and is fair and represents the population that it would meant to serve. That's the second one. The third one is you need to also test and audit that your algorithm is also fair, because sometimes you might have your data is good, but the way you've built your algorithm might be biased. So you have to test for that. And then when it comes to data, you must do what we call a data protection impact assessment. Usually you do this assessment when the tool you're deploying into production is would some way, shape or form impact the human rights of the patient. And that's whether it is access to healthcare, education, or financial benefits, for example. So obviously in this case, if a tool would impact the health of a patient, you must assess how will it impact the data? What data is being used? What's the source of the data? How has the data been transformed in the process of developing that tool? So you conduct that test, and once you pass that evaluation, then you can start thinking of, okay, how do I then deploy this tools? But obviously, these are just a number of frameworks that we use to assess products or tools before they go into being deployed in the real world. But as an overarching framework, I usually tend to leverage the OECD ethical principle. And that means when you're designing your product or when you're using products, you have to ensure that obviously it's fair, it's non-biased, it's transparent. It has to be aiding the well-being of the people. It has to be done in such a way that it is sustainable and the environmental impact isn't severe, because we know that whether we like it or not, AI impacts the climate and the environment. We know how much the data centers consume energy and water and what that does to the environment, and then one very important ethical frame or ethical principle is there has to be governance. There has to be people who are responsible and accountable for the system. And we need to, as a core principle, identify those who are responsible across the different stages of the life cycle. We need to know who is liable at what stage. Usually it is either it's the manufacturer or the provider of the AI product or AI tool who is designing it that is liable, or is you, the user, who is liable. And for you, we need to understand where that liability sits, because if something goes wrong, somebody will be held liable. So those are some of the things that we that I look out for.
Yeah. No, that's good. We have to avoid black boxes, right?
That's a very interesting. The black box situation is very interesting, and that's where one of the trade-off happens in AI. Usually, you find that most black boxes are more accurate and have higher performance, but you can't explain it. Once the explainability goes up, then the accuracy drops. So you have to find the balance.
Yeah, I think that's the key.
Yes.
So, Omasan, in multidisciplinary, high-resistance environments like healthcare, what leadership skill do you rely on most to move AI projects forward ethically?
I would say it's being able to ask the hard questions, right?
Mhm.
Usually, ethical considerations are usually things that come after the fact. Once something has gone wrong, then people start asking the question, oh, did we do this? Did we do that? But one leadership quality or skill that I use is being bold and courageous to ask the question at the very beginning, right? And these are questions around, first of all, do we need this AI tool? Is this something that we must have? Can there be other ways that we can do this more effectively and more efficiently? If the answer is no, great. What is the impact of using this tool on patients' experience or patient outcomes, right? What data is being used to train this model? I remember having a conversation with one of the providers that design AI products, and I said, "You've given us this presentation, fantastic, performance great, accuracy great, but can you tell me about the data that was used to train the model?" That's when people start waffling. It's like, okay, that's something that we would look into. It's like, but you're selling the product as, it's a fantastic product, but you fail to mention that it might not be fantastic in all areas. And we need to have that conversation. And we need to know what to do when it does go wrong. Because it's not a matter of if, it's a matter of when. So if you let us know upfront, then we can plan that into our mitigation plans so that if something goes wrong, we know how to escalate, how to deactivate the system, how to scale back if something happens. So I think being able to have those hard, tough conversations is one of the leadership skills that I definitely use from time to time.
This is powerful because everyone talks about prompt engineering, but nobody is talking about human engineering. Without human leadership, as you said, AI simply doesn't move any complex system, right?
No, it doesn't actually.
Yeah. So, Oma-san, we are going to wrap up soon. And if you could change one thing about AI is currently regulated or deployed in healthcare worldwide, what would it be?
I think the first thing I would do is, and even as I think about it, it's not an easy thing to do, right?
Yeah.
We have devices or tools that are classified as medical grade. So you have to pass certain tests before you can be used in a medical environment, for example. However, there are products and tools and models out there that sort of sit in the gray area. And a very common example is ChatGPT. Sorry to call out any product, but you have this large language models that people defer to, not clinicians, but everyday human like me and you would go and ask medical questions.
Yeah.
They would tend to provide some sort of answer, and we would take it as gospel truth. I was reading out the other day, and there was a guy who went on one of these tools and asked for, how do I moderate my sodium chloride intake? And the machine or the tool gave him advice to take out sodium chloride, which is our natural salt, and replace it with sodium bromide. And he ended up in the hospital with sodium bromide intoxication, And that's because these tools have been left unregulated because it's been not deemed as a medical device. So I think one of the things that I would change is if a product in any way, shape, or form would provide some sort of medical information or medical guidance, it should at least be regulated to a certain extent, or at least the output should be regulated. Because if everyone begins to use that and the impact is at scale, then it's a very serious problem. Remember, there's a family who sued one of these companies because their child committed suicide from advice they got from one of these AI tools. And that's because it's open for everyone and anyone to use, but it's not a medical product. So I think for me, that's one of the areas that I would definitely say we need some form of regulation. But that's the whole conversation between politicians and government. So how that is going to be a reality, I hope is a reality. I don't know yet. So that's one change that would definitely make.
That's nice. So, Amazon, one last question. If you could send one direct message to every AI developer and AI policymaker on Earth, what would it be?
It would be that AI saves lives, but at the same time, AI can cost lives. And in whatever capacity you find yourself, whether you're an AI developer, a policymaker, or even an AI user, I think we owe it to ourselves to ensure that the first happens, which is AI should save lives, but we should do everything in our power to make sure that the second one doesn't happen, that AI becomes the cause of us losing lives, And I think if we begin to see the correlation between those two things, that it can be both, it can't just be one, then maybe we would be in a better place 5-10 years from now. That would be my message.
Yeah, and that's what separates hype from real impact. AI, it's not about moving fast, as you said, and breaking things. It's about moving right, and in this case, saving lives. So thank you so much, Omasan, for this beautiful episode. I really appreciate your presence here. And maybe you can invite people to follow you, maybe, or maybe some of them want to share some thoughts with you. I don't know if you want to share your social media, maybe.
Yeah, no, absolutely. I'm very active on LinkedIn, and it's just my name, OMASAN EDUN. You can find me on LinkedIn. You can follow me on LinkedIn. You can reach out to me on LinkedIn, and anyone who wants to continue this conversation, I'm very happy to do that.
AI is coming for actors, artists, and podcasters. Lucky for you, we're still human. Subscribe now. AI to the Sky.